Hello.
Yes, Dr. Abhijit. We are currently having this open for only for the panelists, so that's the reason only we are able to view it. However, I think in another 2 to 3 minutes we'll be going live. Like we'll be starting the webinar officially.
Yeah,
So we'll wait for people to join after that.
Hello. Hey, can you hear me? It will
Yeah,
start
I'm
at
able to hear
5:30,
you.
na?
Yeah, the webinar is scheduled at 5:30.
Huh.
We'll start the webinar at 5:15 and wait for people to join.
Okay.
Until then, it's open for panelists. The webinar is not yet started, but all the panelists can join in.
Okay, okay, fine.
That's open, but we'll just hold on for that. Okay.
Hello. Hello.
Yeah. Hello, ma'am. Good afternoon.
Hi, I was just checking that the connection and everything was working. Okay.
Yes, working. Your audio and video is perfectly fine.
Okay, I'll mute myself and turn off my video until we're ready to start then, okay?
Yes.
Okay, thank you.
Thank you.
Hello.
Yes, sir.
Hello. Just allow me for this sharing my screen.
Yes, I'll be trying the same. Yeah.
Yes. Because I will start the session and then I will explain you the flow also. It will be easy.
Okay. Yes, yes, I'm listening.
Fine.
Yes, doctor, I'm doing
Okay.
the same.
So see what we'll do. I will start the session welcome and all. So that's why if you allow me to share the screen, I will share the entire agenda with everyone.
Okay.
Sir, if you start sharing, na, so it will come.
No, it's showing host disable participant screen sharing.
So, Abhijit, so what we'll be doing over here is that whenever someone is considering to share the screen, the person needs to be the hosting capabilities.
Okay.
So, I'll be transferring the hosting capabilities temporarily with you. Once you're
Okay.
done with sharing the screen, you can return it back to me.
No,
Okay.
no. Alton, don't do like that.
Don't do that.
It
That
will
will
be
create problem.
very difficult for every panelist to do that. You do one thing for time being, you just make me the host. I'll allow.
I'll just make you the host.
Because what will happen, first I will start, and after me, I will hand over session to Professor Melanie Davis, and then once she finish, it will go to Dr. Jamshed Dalal, and then followed by all the speakers, one by one.
Okay. Okay. So, how many screen shares are we going to observe over here? Or how many people will be sharing, for example?
So I will tell you Dr. Melanie Davis, then Dr. Jamshed Dalal, and then next three. So total 5, including and if you add me, so it becomes 6, right?
Sir, done, sir. You can share now.
Okay.
Can you see my screen?
Yes.
So this is the first slide, and this is the agenda. So I will start with opening remarks and introduction to speaker, moderator, and panelists, followed by Dr. Professor Melanie Davis will talk about SGLT2 inhibitor, cardiorenal benefits and beyond. And Jamshed Dhanal will talk about usage of SGLT2 inhibitor in Indian practice, followed by we'll do a case discussion. So first case will be presented by Dr. Sujay Ghosh, then Dr. Pramila Kalra, and then Dr. Anuj Maheshwari. We will do then after at the ending of all the cases, we will do a question answer session, and then followed by vote of thanks by Dr. Roshan Pawar. So this is the flow of our today's program, and these are the introduction slides. So once I'm done with this, so this is my last slide, Dr. Anuj Maheshwari, and once I finish with this, I will hand over session to Dr. Melina Davis.
Yes.
Hello, hello. Huh?
Sir, good evening.
Hello, good evening.
Yes, your audio and video is perfectly fine.
Good evening, sir.
I'll just, everybody's going to share the slides.
Yes, sir. Everyone individually they are going to share.
Okay, only thing time gets wasted. But anyway, what I was talking to Swapnil just now
Yes, sir.
was that please make the introductions very short, except for her introduction, which of course you should give in detail.
Right.
But for us, just say cardiologist, Kokilaben Hospital, this, that.
Yes, sir. Yes, sir.
Don't need anything.
Yes, right.
And I have a feeling that time is going to be short because I've seen her slides. There are almost 60 slides.
Right.
So she's not going to finish in 25 minutes.
Yes, I will. I'll do it in 25 minutes.
I'm sorry, I didn't hear you.
Yeah, I'll
Excuse me.
I'll go through really quickly. I'll probably be under 25 minutes.
Yeah, I'm Dr. Dalal. I was just worried because there are 3 other case reports. I've got a few slides to
Yeah,
make.
no, I'll never go over time. I'm done this a
No.
few times before. So, and I don't need a long introduction, so that's fine.
Okay. So we'll do that. We just wanted so that the last case report doesn't get left out in the, sometimes what happens is that the last person gets left out if everything goes late. So we just make sure we stick to time and that will be perfect. Yeah. But you're welcome to go over time because you are the main speaker and our guest.
Yeah, no, I won't do that though.
Good evening, ma'am.
Hi, good evening.
Madam, can you just rename if you see your name on the panel? Madam, your
How come this name is coming like that? Okay. I'll rename, don't
yes,
worry.
yes. Good evening, sir. Anush, sir, good evening. Anush, sir, can you switch on your video? We'll check everything is fine. Yes, yes.
Hi, Dr. Pramila. How
Hi,
are you?
Dr. Anand. Hi, fine. Thank you. How are you?
I'm fine, and
Yeah.
I hope you are also looking great.
Yeah, fine at the moment. Hopefully the third wave should not come.
Did you have COVID?
No.
No, that's great.
Don't know.
So,
You had?
yeah, I have experienced.
Oh.
So I got more than 400 antibodies. I'm protected from the third wave up to certain extent. I don't know how much.
Yeah, 4 to 6 months at least the protection may last. When did you get it? Which month?
Which one? This COVID.
Yes.
I have got infected around 9th of May and remained in isolation for up to 24th or 25th of May.
Oh. Got it from a patient, right? You must have got it from a patient only.
But not required hospitalization.
That's the
I
good
was
sign.
vaccinated before, so
Yes,
it
correct.
has gone
People,
quite smooth with me.
right. People who are vaccinated at least don't get severe infection most of the times. But we had some older people who, one of our faculty, like he was very old, like 75.
Younger people has also got so
Right.
many problems. There was one of our colleague in Allahabad, Bharat Arora. He died despite getting vaccinated.
Oh my God.
My sister was being very seriously sick and she has been required to be admitted in Max, Delhi, and she was having 24 out of 25 HRCT, but somehow she could be saved.
Quite scary.
सर बाकी सब पैनलिस्ट आ गए आप एक बार उसको कॉल कीजिए Sir, we can go live next.
Doctor, just tell me when to start.
Hello, everybody.
Hello, ma'am.
Hello.
Hi, nice to see you.
Abhishek, we can start. Dr. Jogos will be joining in a couple of minutes, but
Okay.
to avoid further delay, we can start.
Fine. Good evening, everyone. I am Dr. Abhijit Trailokya, heading the medical department of Alchem Laboratories. Welcome you for Dapanorm Conclave. And today's topic of discussion is SGLT2 inhibitor, cardiorenal benefits and beyond, focus on dapagliflozin. So for today's discussion, we have international faculty with us, Professor Melanie Davis, and the entire program will be moderated by Dr. Jamshed Dalal, and we have a faculty, Dr. Sujay Ghosh, Dr. Pramila Kalra, and Dr. Anuj Maheshwari with us. So let me take you through the agenda. So we'll start with introduction and opening remarks, followed by a session from Dr. Melanie Davis on SGLT2 inhibitor, cardiorenal benefits and beyond. Then Dr. Jamshed Dalal will talk about usage of SGLT2 inhibitor in Indian practice, followed by case discussion by Dr. Sujay Ghosh, Pramila Kalra, Dr. Anuj Maheshwari, and then we will take few questions as per the time permit, followed by vote of thanks. So let me introduce Dr. Professor Melanie Davis. The Professor Davis is the principal investigator on number of large global studies in the field of diabetes, obesity, and cardiovascular disease, and has served as an expert for National Institute of Health and Care Excellence, that is NICE, on number of guideline group. She was co-chair EASD ADA consensus report on type 2 diabetes management. She has published more than 600 original articles in national and international peer review journal, such as Lancet, NEJM, and BMJ. She was awarded the CBE, that is Commander of Most Excellence Order of the British Empire in 2016, the New Year Honor List for service to diabetes research, and awarded fellowship of Academy of Medical Sciences in 2018. So with this, I welcome Professor Melanie Davis. Let's move to the moderator, Dr. Jamshed Dalal. He doesn't require any introduction. He's the Director, Center for Cardiac Sciences at Kokilaben Dhirubhai Ambani Hospital, Mumbai. We have Dr. Sujay Ghosh with us. He's a professor of endocrinology at IPGMER, Kolkata. We have Dr. Pramila Kalra with us, professor and consultant endocrinologist, Ramaiah Medical College and Hospital, Bangalore. And we have Dr. Anuj Maheshwari, professor and head of the department, BBD University, Lucknow, and vice president, RSSGI. So with this short introduction, now I hand over session to Professor Melanie Davis. Over to you, madam.
So thank you very much, it's good to see so many colleagues. I wonder if I could ask people to mute if they're not speaking, as there's quite a lot of feedback. Thank you. I'm just going to request to share my screen so that you can see my slides. I hope you can see my slides. If you can give me the thumbs up if you can see my slides, that would be great. I'm assuming
yes,
that you can. Yeah, thank you. Okay, so I've got just a short time, and this is going to be a real quick overview of the SGLT2 inhibitors. So these are my disclosures. So what I want to cover very briefly is the link between type 2 diabetes and cardiovascular and renal disease, the benefits of the SGLT2s from the cardiovascular outcome studies, specifically look at the recent data in HFrEF and CKD, the guidelines and consensus, safety and prescribing, and then a summary. So a lot to cover in a very short time. So just a few brief comments on each of those areas. So I think we now recognize the clustering of these conditions, so type 2 diabetes and the overlap with both cardiovascular disease and heart failure, and of course, chronic kidney disease. We know that many patients with type 2 diabetes are also associated with, also have obesity and are overweight. We know that there's a much greater risk of heart failure in patients, but we also know that heart failure and chronic kidney disease also co-occur in our patients. And so now we recognize that when we're looking at, for example, glucose lowering and energy metabolism, that plays a critical role both in the health and function of the kidneys, and indeed both of those impact on the heart, which is the most metabolically demanding organ. And this link with heart failure is now understood, and we know that heart failure links with diabetes, even links with glucose even below the diabetes range, and you can see that there's almost a slight U-shaped curve of the risk with HbA1c, which then rises, even as I said, in the pre-diabetes range, and the link with heart failure. Just one final comment about this, because I think increasingly we're interested in reducing the risk of MI, of mortality, and of stroke in our patients with diabetes. And we look to control the known risk factors. And you can see that across the age groups, if you look at excess mortality, if you look at stroke, and if you look at MI, in most age groups, if you're able to control the other risk factors, you can almost bring that risk back to 1. But if you look at heart failure, even if you control the other risk factors, there's still an excessive risk of heart failure, particularly in our younger patients, those aged under 55, but even in the 55 to 65-year-olds. Even if you control other risk factors, there's an excess risk of heart failure. So we need to look at other interventions to reduce the risk of heart failure. Now, I don't need to remind you too much around the SGLT2s, and we shouldn't forget that these are excellent diabetes drugs in terms of glucose lowering. So if you look at some of the commonly used SGLT2s across the globe, dapagliflozin, canagliflozin, and empagliflozin, you can see really across the spectrum that there is a significant good and effective glucose lowering of these agents. If you look at dapagliflozin there, either as monotherapy, combination with metformin, SU, and insulin. And we also know that when we're looking at many patients who are overweight or obese, that they can have very effective glucose lowering as well as being weight losing. So, and as you also know, they have a very low risk of hypoglycemia. So as well as being established as good glucose lowering therapies, we now have a wealth of evidence from the cardiovascular outcome studies with SGLT2s. The studies are summarized in these slides. Empagliflozin was the first study with, EmpaReg was the first study with empagliflozin, and most recently we have Vertis CV. This table summarizes some differences in the size of the study. So DECLARE with dapagliflozin is the largest study conducted in 33 countries. The inclusion criteria varies. So in DECLARE, as you know, there was a group of patients with multiple risk factors as well as established cardiovascular disease. There was some difference in the history, percentage history of patients with heart failure, about 10% in EmpaReg and DECLARE, a higher rate in Vertis. Similar A1C baseline in the studies, some differences in the kidney function. So Declare had the highest eGFR, so in some ways the healthiest patients, and Credence, as you know, was enriched in patients with chronic kidney disease. The majority of patients were on the background of metformin. And if you look at the MACE events in the placebo arm, you can see that the lowest risk patients were in Declare and the highest risk were in Credence. Now, this is the meta-analysis published by Darren Maguire, which summarizes what we know about the SGLT2s in terms of reducing MACE. So if you look at patients with established ASCVD, there's a significant reduction in MACE across the class with an I-squared of around 12%. So very little heterogeneity in terms of the studies. However, if you look in the patients without cardiovascular disease, you can see that there really wasn't a reduction in MACE in those patients only with multiple risk factors. The only slight heterogeneity, 56%, was in Credence, which, as I said, was enriched with patients with chronic kidney disease. If we look at the reduction in cardiovascular death, there is a 15% reduction across the class. You can see that the I-squared is 64, so there is some heterogeneity with a more impressive reduction in EMPA-REG compared to the other studies, but the class effect of 15% reduction. If we look at hospitalization for heart failure, very robust, consistent finding with an I-squared of 0. So no inconsistency in the data in terms of reducing heart failure. So we have a class of drugs which is effective at glucose lowering, reduces weight, and has now evidence of cardiovascular protection from a large number of studies. There's huge interest now in the ability of SGLT2s to protect both the kidney and to reduce the risk of heart failure. And there are a number of direct and indirect mechanisms which explain this benefit in terms of cardiorenal protection. And indeed, if we look at the meta-analysis, including now not just Declare, which is the largest of the studies, but also the more recent but slightly disappointing Vertis study, you can see that there is a consistency in renal protection with the SGLT2 inhibitors, which is by far the most impressive class in protecting the kidney. And here you can see from a further meta-analysis, this is not just about reducing proteinuria, this is protecting significant important kidney outcomes, including progression to end-stage kidney disease, dialysis, transplantational death, and also acute kidney injury. So really impressive and I think paradigm shifting changes in terms of the kidney. This has been consolidated as well as the Credence study, which I mentioned in the specific trial Dapanorm-CKD, which was targeted at patients with chronic kidney disease and had a primary endpoint, which is specifically to look a kidney composite endpoint. And if you can see now that we have Dapanorm-CKD, which showed this 39% reduction, highly significant in this composite kidney and cardiovascular outcome, as well as showing a reduction in the composite kidney outcome alone, and also significant reductions in Dapanorm-CKD in cardiovascular death and heart failure and all-cause mortality, which we didn't see in Credence. Also, there have now been some studies specifically with a primary endpoint of heart failure. This is Dapanorm-HF, which was the first study to be conducted in people with and without diabetes, with a primary endpoint looking at cardiovascular death, heart failure hospitalization, or urgent heart failure visit. You can see the 26% reduction in the primary composite endpoint. So the number needed to treat only 20 patients. In this study, Dapanorm-HF, there was a reduction also in the secondary endpoint of cardiovascular death. And you can see that both patients with and without type 2 diabetes benefited similarly in terms of reduction of heart failure. As you know, there's also been EMPEROR Reduce now, which has been published, and you can see that from this meta-analysis published in the Lancet, if we look at all-cause mortality, there was not a significant reduction in EMPEROR Reduce, but there was in DAPA heart failure, although if you look at both studies together, there is a significant reduction. Cardiovascular death, also a reduction in DAPA-HF, not a reduction, a significant reduction, although a trend with EMPEROR Reduced. But again, if you pull the data, it's in the right direction. A little bit more similar consistency for the first hospitalization for heart failure or cardiovascular death. Similar for first hospitalization for heart failure, shown in the top of the panel. And as you can see, a reduction in the first kidney composite endpoint, if you pull the data, a 38% reduction, and a significant reduction in the first and recurrent hospitalization for heart failure or cardiovascular death. So pretty impressive now data, I think, across now both the traditional type 2 cardiovascular outcome trials with EMPEREG, CANVAS and DECLARE all showing positive results. But now we also have with both primary endpoint for chronic kidney disease in CREDENCE and with DAPA-CKD, and in the heart failure studies with DAPA-HF, EMPEROR Reduced, and also SOLOIST with sotagliflozin. So these are very consistent and reassuring data. So these have started to impact now on the guidelines. And now if we look at the guidelines, we see the guidelines now not just for kidney disease and type 2 diabetes and heart failure and cardiovascular disease, almost becoming intertwined. And there are many now organizations, both in Europe, in Asia, in North America, where there are strong guidelines advocating earlier use, particularly of the SGLT2s in a number of these scenarios. And if you try and summarize these and look at the gray, the type 2 guidelines, the orange, the cardiovascular guidelines, the blue, the kidney diet guidelines, and primary care, you can see that there are now many guidelines which talk about the management of people with type 2 diabetes, either with and without cardiovascular disease and heart failure and chronic kidney disease. Just a few comments about the ADA ESD consensus report, which I was involved with, making the point that we need to put the patient at the center of the care, that we need to focus now on preventing the complications of diabetes. And this was a guideline for the management of hypoglycemia, but it still prioritized the prevention of complications and the optimization of quality of life. Putting the patient at the center of their care, talking about the importance of assessing key characteristics and choosing treatments that target comorbidities, and the importance of shared decision making and agreeing and implementing and monitoring the management plan. The ADA ESD shifted now to picking out those patients with high risk or established ASCVD, chronic kidney disease and heart failure, and advocating the early use of either a GLP-1 or SGLT2 independent of baseline A1C or individualized A1C target. We continue to talk about the use of metformin unless contraindicated or not tolerated, but the early use of the SGLT2 or GLP-1, and also talking about looking differently at whether it's ASCVD that predominates or heart failure or chronic kidney disease. In those patients in whom ASCVD predominates, there is some preference for the GLP-1s, particularly in those with high risk, indicators of high risk, where the evidence is stronger for the GLP-1s. But in those patients with heart failure or chronic kidney disease, then the SGLT2s are preferentially recommended very early. The 2021 ADA guidelines also recommend the early use of SGLT2s or GLP-1s to reduce the risk of cardiovascular events, chronic kidney disease progression, and in heart failure. And they again highlight the independent use of these agents independent of A1C or A1C target. And the European Society of Guidelines of Diabetes almost go a step further. So they talk about in type 2 drug naive patients, in those with established ASCVD, the SGLT2s or GLP-1s should be used even before metformin. Most recent data from KDIGO looking at the chronic kidney disease patients advocate the very early use of SGLT2 inhibitors. They also talk about using these unless the EGFR is less than 30. We know that licensing will change about the use of SGLT2s, but we need to use the drugs in our regions consistent with their license. They also give the algorithm for early addition of SGLT2s in these patients. If patients are already at target, glycemic target, they talk about adding SGLT2s and discontinuing or decreasing the dose of other anti-hyperglycemic medication so that the SGLT2s can be added. Now, just a very few brief words on the practicalities and safety. So the SGLT2 inhibitors, these are the 4 that are most used globally now. As I've said, the advantage, low risk of hypo, weight losing, lower blood pressure, and we've talked about the other benefits. The disadvantages really equate to genital mycotic infections. The other risks, for example, amputation and fracture, are rare and really haven't come through as a major concern in the most recent studies. If we look at the dosing and administration guidance, it's important to remember the recommended starting dose. SGLT2 inhibitors are not recommended in patients who are pregnant or nursing, in children yet, although the studies are underway. And although there is some caution in the very elderly, we have some data, particularly from DECLARE in older patients, that showed a good tolerability in the patients. It's also important, there are now some really good tools to help us with the prescribing of these agents. This is one that is very easily accessible, that talks really about the broad group of patients that we're able to use SGLT2s in. It highlights those patients in whom we need to be more cautious. So for example, in type 1 diabetes, dapagliflozin is licensed and available in Europe, and we use it in that situation, but we do need to be cautious about the DKA risk. We need to be looking clearly at those patients who are on a ketogenic diet, those patients with stage 3B CKD, and those in whom have a recurrent history of UTI or genital infections. And we need to be very careful and avoid using SGLT2s in this smaller group of patients, but those, for example, who've had pregnant, have got eating disorders, or who have had episodes of DKA. It's really, really important to remember around sick day rules with many agents that we use in our patients with diabetes, but we shouldn't forget that SGLT2 inhibitors are safe to use, but we do need to give people sick day guidance, and we've been very proactive about that in our patients during COVID, and we've had no issues of ketoacidosis, but it is important to educate and give people guidance about what to do when they're unwell with their glucose lowering medications. So just very recent data, Emperor Preserved, I think it's just had the press release. There's a study as well with other agents looking at preserved ejection fraction heart failure, for example, dapagliflozin. We only know the data from the press release, but it looks positive. But having told you all these positive things about the SGLT2s, this is a recent publication in Diabetes Care that shows even in patients with cardiovascular disease, that very few people are prescribing. So if you look at the cardiologists, only 2% of cardiologists have been, perhaps up to 4% have been prescribing. And even in the endocrinologists and internal medicine, it's a few patients. So we have these drugs, and yet many of our patients who would benefit from them are not getting access to them. So to summarize, type 2 diabetes is associated with increased cardiorenal morbidity and mortality. Cardiovascular outcome trials now show that there are both classes of drugs, but also differences within classes in terms of cardiorenal protection, and we need to be aware of those differences. The management of type 2 diabetes and offering cardiorenal protection are intrinsically linked. The SGLT2 inhibitors offer cardiorenal protection in people with and without type 2 diabetes, but sadly are still underused in practice. Thank you very much for your attention.
Thank you very much, Professor Davis. You really covered up the whole extent of SGLT2 inhibitors, both in heart failure, heart disease, and in kidney disease. And I think there are going to be a lot of questions, but before we move on to that and before we go for our case discussions, I'm just going to have a quick word about some aspect of use of SGLT2 in India. We've been having it for quite some time now. And as you mentioned earlier in your talks, the SGLT2 inhibitors have a large number of trials, including the most recent one, which again may have benefits in heart failure with preserved ejection fraction as well, showing tremendous benefits in terms of the cardiovascular aspects. I'm a cardiologist, so I'm talking more about the cardiovascular aspects, but obviously I think the kidney benefits are even more. As a cardiologist in heart failure, I have other drugs at least, which the nephrologists don't have. So I think probably it's the most important drug for a nephrologist after all these years of not having any treatment for nephrology. You've already covered all these important points in terms of the benefit of SGLT2 inhibitors. If we look at some aspect of SGLT2 inhibitors in India, and if you look at DCGI, which is from India, you can see for canagliflozin, EMPA, DAPA, and REMO. REMO is the locally made gliflozin. It has been used, though there is no clear approval from the guidelines. And you can see from these guidelines that yes, DAPA has also been approved for use of for kidney disease, and CANA and EMPA have been throughout in terms of CV death, established cardiovascular disease, etc. So the DCGI has approved it for most of the situations. Again, as you mentioned, the use of SGLT2 remains, in spite of so many trials. I don't think any particular drug has had so many trials as SGLT2, and yet the use has been basically whichever of three you use, clearly DAPA and EMPA being more commonly used after the trials compared to CANA, and you can still see that the use is still below 10%. Now, though, as you mentioned, the guidelines and all the recent guidelines have put SGLT2 inhibitors as class 1A drug, it continues to be severely underutilized, even by cardiologists treating heart failure, which is the most surprising. Again, as you mentioned, KDIGO, looking at the use of SGLT2 in renal patients, again, metformin and SGLT2 become the two primary drugs for them to use, especially in association with diabetes and kidney disease. Now, what is it that doesn't make us use SGLT2? Is it the high cost? Not really. We now even have generic dapagliflozin, so I think cost is not a factor. Obviously, inertia is probably a factor that seems to play a part. Just to look at the SGLT2 inhibitor market in India, 2018 to 21, about 3 to 4 years now, the value of SGLT2 market has gone from 428 crores to 943 crores. And you can see the number of patients per lakh, 1 lakh, 10 lakhs is a million. It goes from 2.7 to 8.5. So you can see that, yes, there is a growth, but probably the growth should be much higher growth. If you look at the different gliflozins used in India, EMPA seems to be the favorite with 42%, DAPA 32%, and CANA 15%, with the local brand remogliflozin of about 11%. Now, we heard so much about the 5 alive or the 4 if you combine this together, where SGLT2 is an extremely important player in the treatment, management, mortality benefits from heart failure. And again, if you look at the patients who may be suitable for use of these drugs, again, as you see that 4 out of 5 patients with heart failure with reduced ejection fraction, with or without diabetes. And again, that's very important for cardiologists. The patient does not need to have diabetes in order for us to use this drug. And yet, in spite of that, we seem to have such a poor use of the drug. So 4 out of 5 patients would clearly be suitable for the use of SGLT2, either DAPA or EMPA. But if you look at some of the data, 1/3 of all patients living with type 2 diabetes have established cardiovascular disease, and less than 1 in 4 people are actually being treated with a SGLT2 inhibitor with proven cardiovascular benefits. So there's something obviously wrong, and you can't blame the patient for this, because this is not a question of adherence and compliance. There's simply a question of inertia from the medical side. So as you can see, SGLT2 has grown into a big baby now, from the diabetic indications to cardiac to nephro, and in fact covering the whole spectrum of all the three. And I think though the baby's become big, it's still not yet grown into a full-grown person. So thank you very much. This was just a quick summary of its use in India. And we're now going to move on to Dr. Sujay Ghosh, who's going to present his first of the 3 cases. And then we could have a discussion along with each case. So please, Dr. Ghosh, go ahead with your presentation, and then we can have the discussions along with Professor Davis.
Thank you, Dr. Dalal. Thank you very much. And I think it's going to be very difficult to actually add anything else to what has already been discussed, because we've been talking about SGLT2 inhibitors, and Professor Melanie Davis has actually given us a great overview of the current evidence that we have. And then Dr. Dalal has told us about what the problems of use of SGLT2 inhibitor and current positioning of the drug is in India. And the first declaration that I have is that the case 1 has been given to me by the sponsors of today's program. And this is the case that I've been given. And I've just tried to break up the issues in this case so that we can take up the discussion if we have any confusions about the case. So this is a 60-year-old gentleman whose BMI is 30, has hypertension for the last 15 years, has had diabetes for the last 10 years, is on metformin and linagliptin. For reasons not really very clear to me, is on ramipril with prazosin, has a history of ischemic heart disease, has an old anterior myocardial infarction with an ejection fraction of 30%, blood pressure still uncontrolled, pulse 74. And if you look at the blood sugars or the blood glucose levels, it's 143 fasting and 204 postprandial, which would translate somewhere around 7-ish and 11-ish in terms of millimoles per moles, and an A1C of 8.1% and a creatinine of 1 milligram per deciliter. So the question that I've been asked, and I understand there are going to be 3 cases with regards to the usage of SGLT2 inhibitors in today's program. So I'll go back to the issues one by one and try and reanalyze what we see actually in terms of the clinical data. So the first bit that we are going to talk about is about the body weight, the BMI, and the body fat. Now, if I go back to the case, we've said that the BMI in this individual is 30. Now, BMI is a great marker of or indirect way of telling us about the degree of obesity in an individual, but that is probably true at population level. So you can have someone who's over lean, and when it comes to the SGLT2 inhibitors, Professor Davis made one of the comments was that, if you're thinking of someone who's hypercatabolic, you're not going to use an SGLT2 inhibitor. In India, the unfortunate bit is that if you look at the South Asian guidelines of BMI cutoffs of obesity, it's 23 and not 25 like the Western world. So clearly in this scenario, this individual is likely to be overweight or obese, or it has increased body fat. Now, the challenge and the problem is there's a significant group of patients of type 2 diabetes in India who will not fulfill the criteria of having excess body fat according to BMI, but will have central obesity. So, in future, perhaps we are going to talk about obesity in terms of percentage body fat rather than BMI per se. And anyone with percentage body fat more than 25 in females and more than 30 in males. Sorry, the other way around. In females is going to be probably someone who's got excess body fat. And one of the things that has been highlighted is that the use of SGLT2 inhibitors is actually going to improve the body fat or lower body weight. So in such a scenario, if you're thinking of an anti-diabetic drug, the two drugs that Professor Davis already spoke about, one was SGLT2 inhibitor and the other is GLP-1. So if you're thinking of robust weight reduction, a GLP-1 receptor is probably going to be a better option. But of course, an SGLT2 also would be a good option in terms of the BMI. Coming to the second issue of hypertension, we know that SGLT2s reduce blood pressure slightly. And in this individual who is already on ramipril and prazosin, I think we need to do something else, perhaps replace the, add a calcium channel blocker. And I'm not very sure because prazosin or alpha blockers are not first or second line drugs in terms of management of hypertension. So in this particular individual, we need probably a much more robust ACE-ARB inhibitor, something like telmisartan or olmesartan, addition of a calcium channel blocker and optimization of blood pressure control in this individual. And of course, amongst the drugs which are used for blood glucose lowering, SGLT2 inhibitors have benefits in terms of blood pressure lowering as well. Now, next issue is of glycemic control. Now, if you're talking about glycemic control in this individual, you can see that the A1C is around 8.1. Now, one of the challenges with glucose control with SGLT2 inhibitors is the glucose control isn't that robust. The glucose lowering A1C would be anywhere between 0.8 to 1%. And it's going to be probably even lower the lower the starting A1C is. So that's one issue. We still might not be able to achieve glycemic targets with the A1Cs given here. And the other issue that we discussed was that what other better options do we have in this individual? Of course, switching over to a GLP-1, stopping the linagliptin would be one of the options, along with the addition of a SGLT2 inhibitor would probably be a good option in terms of glucose lowering in this particular individual. Now, the next issue is Dr. Dalal quite clearly mentioned that, a significant proportion, at least 1/3 of patients with type 2 diabetes have underlying cardiovascular disease. This is an individual who already has an old myocardial infarction. Therefore, here in this individual, if you're choosing an anti-diabetic drug, which benefits with atherosclerotic cardiovascular disease, the one that's going to top the list is going to be a GLP-1. Of course, SGLT2s can be used, but in terms of modification of atherosclerotic cardiovascular disease, SGLT2s are nowhere near the level of evidence in terms of the GLP-1. The other drug that has anti-atherosclerotic benefit is pioglitazone, but in this individual, as you can see, the ejection fraction is only 30%, so that drug is out. The other two things that should have been in the treatment armamentarium of this individual is a statin, which we don't find at least mentioned in the history that we've been provided with. We should be using a statin and an antiplatelet agent in this individual who is high risk. The next issue, if you look at, is that this individual has heart failure, reduced ejection fraction. So the ejection fraction is somewhere about 30 only. There, if you're choosing an anti-diabetic agent, of course, SGLT2 inhibitor is going to be right there at the top of the list of the choice of your medications that you're going to use in this particular individual. Pioglitazone is going to be contraindicated, and the DPP4 inhibitors is a bit dodgy kind of a data, with Saxa having bad outcome data. Lina probably is safe, because if you look at both, particularly Carmelina, it included a significant proportion of patients with bad kidneys, where you would anticipate that they would have bad hearts as well. There, they did not have excess heart failure in such individuals. So in this individual, looking at reduced ejection fraction and heart failure bit, the SGLT2s would be a good choice. Now, in terms of renal protection, I brought this point out, even though in this individual, the creatinine is 1 and the individual has got good renal function. One of the reasons why I brought up the question of renal protection is because a lot of time heart failure goes hand in hand with kidney disease. In this particular individual, at least at this point of time, you don't have that, but a significant proportion of people with bad kidneys will have heart failure. and individuals with heart failure will have bad renal function. So their SGLT2s might be a good choice. So on the background of the information provided to me, I've tried to break down and analyze the different aspects of the problems that this particular gentleman unfortunately has, and how we could probably choose an SGLT2 inhibitor in the next step of glucose management of this particular individual. I shall stop there for any questions for discussion.
Thank you very much, Dr. Ghosh. Please keep the case on. Please don't remove the case. Please keep that first slide on. And Dr. Davis, your views on the management and how you would, there looks like very inappropriate therapy out here. So, Doctor, your views on how you would manage the patient, particularly in therapy angle.
Yeah, so I completely agree with Dr. Ghosh. I think that in this case, this patient clearly needs a cardioprotective agent as well as glucose lowering. I think an SGLT2 is the absolutely ideal choice here. I think it would get you close to an A1C potentially of 7%. I think it would help in terms of the weight. I think it would help with the blood pressure. I think it would be a much better choice than a DPP-4 inhibitor. The patient's already on a DPP-4, so we could add an SGLT2. I think the only challenge would be to make sure that you counsel and explain to the patient about how the drug works, and that they take it and tolerate it. And the vast majority of patients who I see like this would do well on an SGLT2 and would come back actually quite pleased, because they would have lost some weight, their A1C would be coming down, and we can be I think reassured that we're offering them cardiorenal protection. So I would talk about this as an investment for the long term to the patient.
Thank you very much. As a cardiologist, I would change this treatment completely. For example, I would replace ramipril with ARNI for sure, because there's so much evidence that ARNIs are better. In fact, the indications and guidelines suggest that even if the patient's well on an AC inhibitor, it's better to shift on an ARNI. So I would change the patient from ramipril to ARNI, number one. I would definitely stop brazosin. I would add a beta blocker because the ejection fraction is low, and beta blocker is one of the 4 pillars. Again, because potassium and kidney is not an issue, I would add a mineralocorticoid antagonist, because again, that's one of the 4 pillars. So clearly this patient, if I were treating, would be on ARNI, mineralocorticoid antagonist, spironolactone, and a beta blocker, maintaining the heart rate around 60 to 65, which is also beneficial in patients with reduced ejection fraction. As far as the diabetic drug therapy is concerned, of course, SGLT2 inhibitors would be right on top of my list. But I would like to ask this question to Professor Davis as well. Why not combine, which we often have done, SGLT2 and GLP-1 both? So metformin plus SGLT2 inhibitor plus a GLP-1 antagonist, and would be a good choice of therapy. I mean, can we combine the two?
Yeah, I wouldn't go straight away with that combination, because I think there's I think you want to get the patient's confidence, you want to make sure they tolerate the agent well, and I would get DAPA, get them on that, or EMPA, DAPA or EMPA, get them on the dose and see where you are. And I agree, though, that with a BMI of 30, you may need additional treatment. And if the A1C was still a bit stuck above 7%, then personally, we use quite a lot of GLP-1, SGLT2 combinations. And I think with the weekly GLP-1s and now the oral GLP-1s, they're pretty well tolerated. But I think I would, rather than start them both together, I would go first with the SGLT2 and then add a GLP-1 if required.
Dr. Kalra, any points would you like to make, or Dr. Maheshwari, would you please come in and make your comments? Dr. Kalra?
Yeah, actually, I agree with Dr. Sujay Ghosh's approach to this treatment. And I also agree that in such a patient, one drug may not be sufficient, because we also have to, the first thing we have to always think about is the glycemic control. And the glycemic control may not be achievable with one drug addition. So we might have to go with definitely 2 drugs, and maybe a stepwise, but not the stepwise what we conventionally say, the stepwise after 3 months, maybe we add and then we add another drug, because sometimes there may be tolerability issues and multiple things. And SGLT2 and a GLP-1 combination would be the best choice for this patient if the other factors are not involved, especially the cost factor, because many a times we would like to give SGLT2 and GLP-1 combination in such patients, but there are multiple factors, including the cost, which comes into play. And also, as you said, that we need to modify the cardiac treatment as well. And also, it is very important that when these patients come to us, we need to always talk to them about lifestyle modification and diet, because many a times we do see that we do the best with regards to the drug for the patient, but the other factors like the lifestyle is not paid much heed to. So I think that is also one factor which I would like to add should be clearly looked into, and the patient needs to be counseled specifically about that as well at every visit. This should be done at every visit. So that's another thing I think would be beneficial if we do that, because the patient is obese and this patient needs to be told about the benefit of weight loss and correct lifestyle and correct diet. And we need to see whether the patient is following that and what type of exercise the patient can do. That all needs to be stressed on, because this patient already has an ejection fraction of 30. So we cannot expect this patient to be able to do much of great exercise, but whatever best possible with the physiotherapist consultation, this can be planned for the patient.
Thank you very much. As we all know that if you put the patient through a proper cardiac rehabilitation program, there's not only a significant improvement in quality of life, but even their mortality is improved. So clearly rehabilitation should form a very important part of management of all these patients. Dr. Maheshwari, would you like to continue?
Yes. In this patient, I would like to add SGLT2 inhibitors without taking anything out, and once I will try to get the glycemic control. Would like to add the calcium channel blocker in the ramipril. Of course, prazosin should be replaced with the beta blocker. This would be the first thing what would I like to do that. After the glycemic control is achieved or not achieved, in that condition, I would try to replace linagliptin with the GLP-1 receptor agonist, and that would be the ideal approach in this condition. Of course, the statin must be there. Without statin, and lifestyle modification is again a very important part which must be enforced such kind of a patient, because I have seen that patient, those who are having so much less of the ejection fraction, they don't bother for the lifestyle modification much. They don't go for the walk. They think that they are having the weakness and kind of the situation. They are having the breathlessness kind of the complaints most of the time. So we need to promote and enforce the lifestyle modification while doing all these things. So that's all.
Thank you. I'm sorry, I slightly disagree as a cardiologist from the thought process which two of you made, which was the use of calcium channel blockers in this drug. Calcium channel blocker drugs in heart failure with reduced ejection fraction have no role to play. They do not change the quality of life. They do not reduce the mortality or improve the survival. So I think there are better drugs available. Of course, clearly ramipril, I would stop and change to Arni, which would itself be a very good antihypertensive drugs. And if you took it to about 200 milligrams twice a day, you'd probably find no need for any other BP reducing medicines. Also, because beta blockers are important, I would add a beta blocker. And I have a question here from the audience as to whether I would use bisoprolol or carvedilol. There are 3 beta blockers which are useful: bisoprolol, carvedilol, and metoprolol. And you can use any of these 3, it doesn't matter. I would certainly use a mineralocorticoid antagonist, which would again bring the blood pressure down. So in my opinion, I don't think we would need a calcium channel blocker at all. I would rather optimize the dose of Arni, MRA, and beta blockers to get the blood pressure under control, also to get the heart rate under control, and then of course see what to do. Only in extremely severe hypertensive patients who do not get control with this combination, I would think of a calcium channel as an additional drug, but not as a primary drug for treatment of hypertension. That's my only difference of thought process. So I think we can now move on to the second case, and we can have discussions on that. So Dr. Kalra?
Yeah, sure.
Yeah, please go ahead.
I hope my slides are visible. Yeah.
Yes, please.
My case is a little bit similar to Dr. Ghosh's case, but a little bit different as well. So this is a 60-year-old lady whose BMI is around 28.5. So she's obese as per the Asian criteria. She has type 2 diabetes for around 9 years now, and she has history of CABG, which was before the diagnosis of diabetes. That was 10 years ago. She is on metformin 1000 mg twice a day with glimepiride 2 mg once a day. Now, her urine albumin creatinine ratio repeated on 2 different occasions has shown positive. Once it was 39, the next report was 124 with no evidence of urinary tract infection at that time. So she's having albuminuria. Her eGFR is 65, and she also has glucose fluctuations. One time it goes high, low, all glycemic variability is happening. The parameters which are available as per the case are like fasting plasma glucose is 146, her postprandials are 270, and her HbA1c value is 8.6. So again, we are discussing here that would SGLT2 inhibitors be an option in this patient. So I had these issues to discuss for this lady. Now, the first and foremost thing that whenever we have a diabetic who comes to our clinic, the first thing we always have to see and target is the uncontrolled hyperglycemia, because that's the first thing which needs to be controlled. Because if the glycemia is not controlled, we cannot have any control on the complications, no matter whatever best we do for the patient. So with regards to that, we know that her HbA1c is 8.6. So only adding an SGLT2 inhibitor would not be sufficient for this lady, because that would hardly bring the HbA1c down by 0.8%. If I keep the glimepiride there and I obviously keep the metformin there, then I have to think about adding another drug which will help not only in bringing down the HbA1c, but also be beneficial for the other things. So again, I come back to the same point, what we discussed in the last patient as well, that this type of a patient who is obese, has diabetes, has a history of bypass surgery, is presently doing fine, but has hyperglycemia, uncontrolled glucose values, would be a right candidate definitely for SGLT2 and GLP-1 combination, which would work best for this patient. And obviously, I may not be able to take off her sulfonylureas totally initially. I will have to add SGLT2, then add GLP-1 and see. Many a times we see that once they lose weight, the glycemic control becomes better, and then we can slowly reduce the sulfonylurea. She is also post-CABG. So then again, these two drugs which have definite cardioprotective effect or benefit on the cardiovascular mortality, that is the SGLT2 inhibitor as well as the GLP-1, would be the drugs of choice in this lady. And then we have to think about maybe if the glucose values are not coming under control, we can think about basal insulin and other things. But what we see in this lady is the postprandial hyperglycemia, which is more predominant. Also, this lady has albuminuria. So again, when I talk about albuminuria, we know that SGLT2 inhibitors have definite protective effect on the kidney, and we know that diabetic kidney disease is one of the major causes of mortality in patients with type 2 diabetes. So if a patient has already got albuminuria, this is the right time when I should give her the drugs which have good effect on the renal outcome, like SGLT2 inhibitors. So again, an SGLT2 inhibitor would be a good drug to add here, because we know they have multiple protective mechanisms with regards to the kidney as well. Not to forget that this lady is obese. Now, whenever we think about anti-diabetic drugs in diabetes, the first thing we have to think about definitely the glycemic control. And the second thing we have to think about avoiding the hypoglycemia. And the third thing I have to think about is reducing the weight. So if I put SGLT2 inhibitors as well as GLP-1 here, I know that both these drugs together will definitely help in reducing the hyperglycemia. They will also help not only for the cardiac and the kidney, but they will also help to cause less hypoglycemia, because my worry would be that if in this 60 years old lady, I increase the sulfonylurea, I'm risking her for a higher incidence of hypoglycemia with more weight gain and not giving any protective effect on the cardiac and the kidney, apart from controlling the glycemia. But when I give her drugs like SGLT2 and GLP-1 here, I'm going to give her a benefit not only on her cardiac outcome and kidney outcome, as well as I'm going to help her in reducing the weight. Can we please mute the mic, please? Yeah. So I am also going to help her with reducing the weight. And once the weight loss happens and the visceral fat reduction happens, it again translates into further cardiovascular outcome benefit and also in the reduction of the blood pressure as well. Though in the case, we are not sure if this lady also is on another drug for hypertension, but what we can understand that she is post-CABG, maybe she had, but there's no history of hypertension as such written in the case. That information we don't have. But we also know that if this lady will reduce her weight, she will definitely have a good effect on the cardiac, as well as to a great extent on the renal outcome. Now, the most important thing which we are now talking about, apart from the glycemic control, that is only the basic fasting and the postprandial and the HbA1c, is the glycemic variability. Now we talk about more things like time in range, how much time the patient is spending in range with the glucose values in the range of like 70 to 140, if we say, or for older patients, we can keep it like maybe 80 to 150 to 160. and how much of the time they are spending below the range, that is the time which they are spending in hypoglycemia, which should be as less as possible, and how much time they are spending above the range. So I would also be happy to give her drugs which have been shown to have a good effect on the glycemic variability. We know that DPP-4 inhibitors as well as the SGLT2 inhibitors have data on controlling the glycemic variability or the glucose fluctuations as well. So another thing which would also add more to her macrovascular complications as well, because we know that glycemic variability has been shown to have a bad effect on the carotid intima media thickness and some other cardiovascular risk markers as well. So glycemic variability would also be an important factor in my mind when I'm treating this lady. And I would definitely be targeting that as well. So a combination of SGLT2 inhibitors and GLP-1 would be a good drug to add in this patient. Along with that, I would try over a period of time to maybe reduce the sulfonylurea because her HbA1c is 8.6. So when I add the SGLT2 and the GLP-1, I'm expecting a good drop with the weight loss over a period of 3 months. And slowly I should be able to take away the sulfonylurea and maybe continue her on SGLT2, GLP-1 and metformin. So that is how I think would be the best approach for this lady. And also I would like to definitely review her cardiovascular drugs and see that she is taking them regularly, and also would like to see that what are the other drugs she is on, because I suppose that she is on statins, she is on antiplatelets, so all that would be there. And I would like to see her lipid values and the LDL values if they are in control, because that also is an important parameter for the outcome of this lady. So these are the things I would definitely like to see and follow up. And one more thing which I would also want to see, because she already has albuminuria, I would get her retinopathy checking done, because the fundus report is not available. So that also needs to be checked, because I have to check if she has also got that as well, because the albuminuria has already set in. And that would also help me to further decide about her management as well.
Thank you very much, Dr. Kalra. So Dr. Davis, your comments on the case and any other points you'd like to make?
Yeah, so I'll focus just from a diabetologist point of view. So I broadly agree. I think I wouldn't go straight in with a combination. I think we have to remember that the mean A1, I agree that in the average patient, we won't expect much more than a 1% drop, but that's an average, and we have some people that respond a little better, and some people, if they've not been taking their medicines, if somebody's got fluctuating glucose levels, they may not have been taking their medicine. We know that poor compliance with our medicines that we prescribe is quite common. So, and I think Dr. Kalra mentioned earlier the importance of emphasizing lifestyle and dietary compliance. So I would remind the patient about that, but then go in early with the SGLT2 and see where we get, because sometimes when people start to notice an improvement in the glycemic variability, they start to lose weight, they get more confident, and they may then comply with their other medication better. But I agree that if she doesn't get to target and you've emphasized all of the other things, the reason I go with the SGLT2 first is because of the microalbuminuria and the renal protection. But then we do have options. We do have the weekly GLP-1s, which I think are really easy to use now. And we've certainly in Europe, we've now got the oral GLP-1s, which we have the option of adding, which is fantastic. But I think I would want to see the response first to the SGLT2 and get the patient's confidence. But yes, in all and I do agree that it would be good to get off the SU, really. I think often the SU can be, if there was the option to look at continuous glucose monitoring, often we see undiagnosed hypoglycemia and fluctuations in glucose, which so if we can get the patient off the SU in the longer term, particularly from a weight and hypo point of view, that would be good. But I broadly agree with Dr. Kalra's approach.
Professor Davis, you mentioned that because of the renal disease, you would prefer SGLT2 as the first drug. Suppose this patient did not have any kidney problem and just came to you with a history of bypass, would you then choose GLP-1 as your first choice?
Yeah, I think then it's a conversation with the patient, and I think that's where the care planning comes in, because I think it's great to have a choice now. We use quite a lot of GLP-1s. I think some patients, the expense is a problem, and the fact that they're injectable can be a problem for some patients. In our patients, I have a lot of South Asian patients in Leicester, where I live. We have lots of people on GLP-1s. We have lots of people on SGLT2s. I think for some people, the attraction of greater weight loss and the weekly injection is actually, they would prefer that than a daily tablet. But if the microalbuminuria wasn't there, and it was more an atherosclerotic cardiovascular disease, I agree that Dula or Sema we tend to use weekly here.
Dr. Ghosh, any comments?
No, I think compared to the first patient that we discussed, the couple of things that was different here was that you need a much more robust glucose lowering in the second case. And you've got an SU on board. That's where you're worried about the glycemic variability, hypoglycemia. And the third issue was renoprotection. I think we've discussed all three issues. And I agree, even though we would know that the evidence for a GLP-1 is more than an SGLT2 inhibitor, but in India, because the patient is paying out of his pocket, using a GLP-1 is not always possible. And now we have generic SGLT2s that you've talked about, which are cheaper. Injectables are less readily accepted. And unlike perhaps what the Western data suggest, tolerability of GLP-1s, particularly in the recommended doses in Indians, is a big challenge in a significant proportion of people. For example, if you're looking at, say, Victoza, people would say you go up to 1.8. I hardly can, push it up anywhere beyond 1.2 in most of my patients. So tolerability of GLP-1s in the Indian population is a big challenge.
Dr. Maheshwari, your comment, please.
Yes. As far as the second case is concerned, I find my priorities three important things. One is the weight management. Second is the control of fluctuations or glycemic variability to correct. And third is the albuminuria, which is going to impact on the prognosis of this patient. Regarding this, I would like to keep my patient on withdrawing from the sulfonylurea, and so that the glycemic variability can be maximum reduced. And of course, the SGLT2 inhibitors and GLP-1 receptor agonists should be the priority. And of course, hypertension control would be there if it is there. Albuminuria is a very serious concern for any diabetes patient. So it reduces the longevity of the patient. But there are certain drugs, especially the GLP-1 receptor agonists as well as the SGLT2 inhibitor, we both have the positive impact on the albuminuria. And of course, the hypertension control, we should choose the drugs like ACE inhibitors or ARB, which can have a good impact on the albuminuria. That's all.
Professor Davis, I would like to ask you a question.
Dr. Dalal, can I just come back on Dr. Ghosh's comment about tolerability of GLP-1s in South Asian patients? I mean, I think the tolerability of GLP-1s is a bit of an issue for all populations. I mean, 50% of the city of Leicester are South Asian people, and many of them have diabetes, but we don't see a difference in the tolerability in the different ethnic groups. I do agree that you need to start slow and go slowly with GLP-1s, but I think the tolerability is a general issue. I think with the weekly GLP-1s, it's a little bit easier to deal with, and we don't get many of our patients up to 1.8 of liraglutide, but we have Dula and Sema now, which we can start weekly, and they do seem to be a little better tolerated, although in clinical practice, I have many patients on 0.25, 0.5 of Sema and don't need to get them up to the milligram because they do pretty well on the lower doses. So, but I don't think that's a South Asian population issue. I think it's just generally how we use GLP-1s.
So there is a question unrelated to SGLT2. You have a diabetic patient, he's got no kidney problem, no cardiac problem, nothing else except diabetes. When would you use an aspirin? When would you use a RAS blocker as a prophylactic management for these diabetic patients with no background history of renal or cardiac problems?
Yeah, that's changed a little bit in the UK. So from the Ascend study, we don't use aspirin so much as we used to, but I think often when you say a patient without any signs, I think the harder you look, the more often there are signs in our patients of excess cardiovascular risk. We see a lot of younger patients with type 2 diabetes now, and many, if you look, do have excess cardiovascular risk factors. So they are used, and I think in terms of RAS blockers, then really it's the microalbuminuria that would determine that. And there's now in primary care, GPs are paid essentially to make sure that we screen. So there are many more screenings done now in primary care to pick up patients earlier.
So to answer to your question is that you would not routinely use aspirin or a RAS blocker in your diabetic patients unless there is a high CVD risk score or something like that?
Yeah, so if they've got normal blood pressure, no microalbuminuria, there's no other risk factors. But as I say, many of our patients are hypertensive, or they do have microalbuminuria, or they have other risk factors. But if in the patient you describe with absolutely no other signs, we wouldn't know.
What about statins in a patient whose LDL is not raised but only has diabetic and has no cardiovascular disease? What is the UK?
So if a patient has an absolutely normal LDL cholesterol, no symptoms, no family history of cardiovascular disease, again, we wouldn't put them on a statin without, but the majority of patients will have, you know, a modestly elevated LDL, a family history, or other risk factors. So the patient you describe is pretty rare.
I'm going to ask this question to my Indian panelists as well, because somebody in the panel on the question in the audience asked that we are talking too much about glucose-centric approach. Talk about other things as well. So I'm specifically asking in the Indian context about aspirin, RAS blockers, and statins. What do you all do? So you can take it one by one. Dr. Kalra, please.
So statins definitely above the age of 40. If we have a diabetic who is above the age of 40, we are giving to all. But as per the guidelines, we are supposed to give moderate intensity statin. But I would accept that most of our patients are not taking actually the moderate intensity statins. They are taking the low intensity statins, like suppose we are supposed to give 20 mg of atorvastatin, we are using only 10 mg. Or if we are supposed to give 10 mg of rosuvastatin, we are using only 5 mg. So that's one thing. Below the age of 40, then if we have the risk scoring and if the patient is a high risk, then only we are using statins. Or if the LDL values are in that target beyond 100, then only we are using it. But if it is a high risk patient, then only below the age of 40. But above the age of 40, we are giving to all as of now. But it is not moderate intensity. In many of our cases, we are giving low intensity also. But also to understand secondary prevention, they are all on high intensity statins. So there's no controversy on that. But when we are talking about aspirin, most of the patients who are in the primary prevention nowadays, with the latest data available, we are not offering aspirin to them. But yes, again, then it comes if they are very high risk cases or some other, the risk factors are there, then it's a different story. But if they have diabetes, hypertension, smoking, then that patient comes into that high risk category. Otherwise, for primary prevention, most of them we are not giving. But for secondary prevention, again, there is no controversy. All of them are on antiplatelets.
Dr. Ghosh?
I think I would agree with what Dr. Kalra has stated, particularly with regards to the statins. You know, we are probably somewhere in between the American guidelines and what, in terms of what we are doing, in terms of the intensity of the use of statins, and in terms of the American guidelines where they've actually almost used it blanketly in everyone. Probably not in everyone, but at least everyone above 40 we are using. And in the younger group, probably if they have raised lipid levels or have additional risk factors. In terms of the antiplatelet agents, I think only if individuals, like Professor Davis said, have other risk factors like, say, microalbuminuria or pre-existing cardiovascular disease or hypertension, or are smokers, there we are using the drug. In terms of the ACE inhibitors and ARBs, if an individual is normotensive and is normoalbuminuric, these are two situations where that's the situation where we are probably not using an ACE inhibitor or an ARB. In all of the other situations, we are probably using an ACE inhibitor ARB.
Dr. Maheshwari?
Yes, as far as my idea is concerned, I think that statin should be given as early as possible. So I don't find any problem giving the statin earliest in the diabetic patient, because all the diabetes patients start their pathophysiology with the endothelial dysfunction, and statin is the thing which can stop it and which can interfere in the development of this pathophysiology. So if the patient is diabetic, the statin has a very important role, even less than 40 years also. Although guidelines are there or not there, that is a different issue. Second thing is that as far as the aspirin, I agree with my colleagues like Dr. Sujay Ghosh and Dr. Kalra that I will not be going if it is not for the secondary prevention, not for the primary prevention, I won't be giving. And of course, the RAS blockers, I have the same idea what the Sujay Ghosh has said. So there is no different thought in that way.
Thank you. As a cardiologist, I would like to point out that in India, high LDL values are not a common phenomena even in patients with multiple coronary events. So we do not see the high LDL values which we see in the Western world. So an LDL of 110 could be well associated with cardiovascular problems. So our thinking, or my thinking at least, is to put all diabetic patients on statins, because I think the risk-benefit ratio falls more in terms of benefit rather than the risk. So if I see a diabetic patient, I would start on statins even if you all haven't started it. As far as aspirin is concerned, I agree with all of you that aspirin risk benefit goes against the benefit and more towards the risk, especially with all the recent trials. So aspirin, I would not start a patient on aspirin just straight away. But if the patient is diabetic with the family history or with some associated other risk factor like hypertension or any other issues, then of course I would start aspirin as well. But I think statins would be my easy choice and not the aspirin. So having said that, we'll move on to the last case. Dr. Maheshwari, you'll be presenting that.
Yes. Yes. So hope you can see my screen.
Yes, please.
So this third patient is the youngest of all the three patients, 45 years, old lady with type 2 diabetes for 5 years. On metformin, sustained release 2 grams per day, glimepiride 1 milligram once a day along with lifestyle modification. Hypertension since 2 years on telmisartan 40 milligram and amlodipine 5 milligram once a day. Dyslipidemia with high cholesterol and LDL on rosuvastatin 20 milligram per day. Presented with hyperglycemia and hypertension. Family history of premature coronary artery disease is very strong. One brother died of MI at the age of 36 years and his sister underwent CABG at the age of 40 years. So it is highly vulnerable family history. On examination, patient is having 29.4 BMI, almost similar to the previous patient. Pulse 70, normal. Blood pressure is high, 164 by 98, significantly high. HbA1c 7.9%. Fasting 149, postprandial 270, serum creatinine 0.9, cholesterol 223, and LDL cholesterol is also raised 134. So what will be the next step? As far as this case is concerned, my priorities would be, apart from controlling glucose, to meet the challenges of hypertension. Already patient is taking 2 drugs of the hypertension but not controlled. Dyslipidemia, a strong family history for cardiovascular disease, which is the biggest concern in this patient, and obesity. And of course, a strong family history of cardiovascular disease can only be can only be resolved and can only be taken care if we take care of the hypertension, dyslipidemia, obesity together while doing the glycemic correction. So what the available options are with us? One is we simply change the number target by increasing the dose of the sulfonylurea, or we add the DPP-4 inhibitor, what usually happens in normal cases. Normally, once such kind of the patient comes to the physicians, they opt any one of these options. Most of the time, they are supposed to be the cost effective, but in the long run, they are not cost effective. In fact, they are much costlier when you add the cost of the CABG and other kidney complications which may come up. Ideal options could be in this patient GLP-1 receptor agonist, because my bigger concern is the weight reduction. At the same time, I am seeing that patient is having LDL very high. SGLT2 inhibitor should be added or can be added to the GLP-1 receptor agonist, but I would like to give it as a first therapy, because SGLT2 inhibitor, already the patient is having the higher LDL despite taking the 20 milligram of rosuvastatin, which is a quite handsome dose of the rosuvastatin. So I will go with that. And apart from that, for the correction of hypertension, I shall like to add the drug which has not been used like already the patient is taking the ARB and calcium channel blocker, I will try to increase the dose of them. I will try to add the beta blockers in this patient. And also I can consider the diuretics, especially the natrilyx SR kind of the diuretic, which do not cause electrolyte imbalance in association with the SGLT2 inhibitor. So in GLP-1 RA, what the pros is the weight reducing, CV protection, lipid and blood pressure lowering. But again, the problem is that injectable intolerance issue remains in the Asian population and cost is high. SGLT2 inhibitor having the favor of they can be very good heart failure, but patient is not showing any kind of the heart failure at this time. But having the strong history of the cardiovascular disease, weight reduction is very much important and weight reducing potential should be used. SGLT2 inhibitor has been seen by that having the weight reducing potential, but after some time it gets a plateau. So GLP-1 receptor agonists have been found to be more weight promising in the weight reducing potential. But of course, SGLT2 inhibitors are easy to administer, although we should be careful about the euglycemic ketosis. And LDL raised is a thing which may keep it in the second option. And cost is now we are having the economical SGLT2 inhibitor also. We can use them if the cost is a concern. So lowering cardiovascular risk should be the priority instead of simply chasing the number target. It helps in reducing cost of complications and untimely death due to CV disease, as this patient is showing the strong family history and has the history of one death in the family in the early age also. Thank you very much.
Thank you very much indeed. I'm surprised that whoever made the questions and we are talking of SGLT2 hasn't bothered to put the ejection fraction of most of the patients because quite a bit would depend on that. Professor Davis, your comment on this particular case?
Yeah, so I think this, so the difference here is that we have somebody 2 decades younger. So this is a woman in her 40s. So I think that, that already raises huge alarm bells, doesn't she? She may well have dependents and children that she's responsible for. She's got decades of this to come with already an incredibly strong family history. Already, if you were to adjust her BMI, she'd be well in the obese range for her ethnic group. And she has very poorly controlled blood pressure and lipids. So clearly the focus needs to be on trying to reduce her blood pressure and lipids. But in terms of her glycemic control, I mean, here I would speak to her and look at her priorities, but I think a GLP-1 here would be quite important because it will clearly get her to an A1C target. It would clearly help her lose significant weight. And I think with somebody with a strong family history of atherosclerotic cardiovascular disease, the data is a little bit more compelling with the GLP-1s than it is with the SGLT2s. But she's likely in the medium to long term to need combination treatment. But I think this is, she's in a very high risk group and has a significant chance of a lower life expectation because of a cluster of these problems at a relatively younger age.
I think this would be the sort of patient I would put on aspirin. This is the patient I would be super.
Yeah, so exactly. So she's got, I agree. And the other thing, I mean, I know the comment about the LDL, I mean, in the context, if you were to need an SGLT2 here, which you may need to do in combination and certainly within, I wouldn't be so worried about the very modest effect that SGLT2s have on LDL in the context of agents now that we can use, but also in the context of the cardiovascular outcome trial where there's no hint that increase in LDL is a signal for poorer cardiovascular outcomes.
Well, that's just for the audience who do not know that SGLT2s do produce a little bit of increase of LDL, and that has been a concern, but clearly the cardiovascular benefits are far more than the little elevation of LDL. Again, in this patient, since we are talking of LDL, I would be extremely aggressive with lowering her LDL, maximize the dose of statins as ezetimibe, and even if necessary, use PCSK9. If you want this patient not to follow her siblings, then you need to keep her LDL really low. And I think that's probably the most important to prevent future deaths. Professor Davis, I'm going to ask a couple of questions before I move to the other panelists because the audience has asked that. You have a patient who was advised fluid restriction because the patient's in heart failure, and you started on SGLT2 and now he's got urinary tract infection. So should you give more fluids or less fluids?
If they've got they've got a urinary tract infection, I think you need to treat the urinary tract infection and make sure the patient is well. You can temporarily stop the SGLT2 in that situation. If you wouldn't want somebody with an active UTI in a hot country where they may become dehydrated with other things. So I think you need to implement your sick day rules in that situation and treat the UTI. Actually, the UTIs, if you look at the meta-analysis, are not particularly increased with SGLT2 inhibitors. UTI are more common in people with diabetes anyway, but certainly with DAPA and EMPA in the big series, there was early concerns about UTIs, but we don't really see that. But I think it's more the acute infection that should be treated. I think that overall, SGLT2s reduce acute kidney injury. So actually, and in many of the studies, these are patients with comorbidities on many other medications. So I think overall, these drugs are safe in terms of protecting the kidney, even in the face of acute complications.
And the other thing about the SGLT2 is they also prevent the potassium rise that happens with the use of ARNI and mineralocorticoid antagonists. So clearly, addition of that will help you to control the potassium better and continue the patients on MRAs and ARBs. So that's an additional benefit as well. Professor Davis, again for you. Couple of questions on microalbuminuria. Once it sets in, what is the best way to reduce it? So maybe a little more thing. You control the sugar; it's very well controlled. Microalbuminuria is present. What do you do next step in terms of reducing that?
Yeah, so the DECLARE data is quite interesting because they had patients right across the spectrum and even looked at those patients where you couldn't detect microalbuminuria on sort of routine, so even sort of microalbuminuria, if you see what I mean. And they showed a benefit of SGLT2s of dapagliflozin in that study right across the spectrum. And the argument, actually, if you don't look from a cost-effective perspective, the argument is that even in patients with normal albuminuria, that in that study, there was a potential benefit, a hazard ratio reduction in reducing progression to chronic kidney disease. Of course, the absolute benefit was very, very small because the risk to those patients is very low in the first place. But the argument is that SGLT2s really right across the spectrum of chronic kidney disease can protect the kidney. I think we need, clearly the DAPA-CKD and Credence were done in people with established chronic kidney disease. So we'd need to do the studies and we'd need to know the cost effectiveness in the broader sense. But, from that analysis of DECLARE, the benefit seems to be right across the spectrum. And even if used very early, even in people with virtually normal renal function, there is kidney protection.
Dr. Ghosh, would you like to make a comment and maybe answer this question? What is the role of voglibose in treating diabetes and how often do you use it in India?
Right. I think AGIs are alpha-glucosidase inhibitors are used quite a lot in the Asian population, whether you're talking about Indians, Japanese, Chinese, and you are using it predominantly as a prandial glucose regulator, where you've managed the pre-meal blood glucoses quite well, and where even after with dietary modifications, you still find their postprandial levels are slightly higher because these are not very potent drugs. They, in terms of regulating just slight high peaks of postprandial glucose, you would be tempted to use AGIs.
Dr. Kalra, if you give a patient, this is a question asked, if you give a patient SGLT2 inhibitor and a GLP-1, how much weight loss do you expect when combining both?
See, that depends on multiple factors. First thing is, then when we start SGLT2 inhibitors, if you see the studies, they have shown 2 to 2.3 to 2.7, but we may see in our practice much more. Now, there may be varied reasons for that. First thing is, that if suppose the patient is on insulin and I've added SGLT2 inhibitor, so whatever weight gain was happening because of insulin, that weight also a little bit comes down because the insulin dose comes down. It's not that we stop the insulin, but we may reduce the dose of insulin and add SGLT2. Second, if the patient is on drugs like sulfonylureas or pioglitazone and we take away those drugs, then further weight loss happens. So we have seen sometimes even higher weight loss, like I have seen even maximum of 8 to 10 kgs also in some of my patients, not like that I've seen in all, but yes, 3 to 4 kgs is what we see. But when we add GLP-1, I've seen even higher, much higher weight loss. And with GLP-1 analogs, we sometimes also, the thing is that I have seen that the patients start following the diet very strictly and they will follow everything. And over and above the GLP-1s, we see the lifestyle is strictly followed. And when we combine these two drugs together, then we may have even higher weight loss to the tune of 8 to 10 kgs seen in some of our patients. But some of our patients, we have seen an average of 6 to 7 kgs, depends on what are the other drugs which are withdrawn, like insulin or pioglitazone or sulfonylureas, which also add to the weight gain. So once these drugs dose is reduced or withdrawn, that also adds to the weight loss which happens with these drugs. So that's why it varies. But in the studies, we have seen like 3 to 4 kgs, we'll say with GLP-1 up to 5 kgs. And with this SGLT2, we see around 2.7 average, but we see a little bit more sometimes in many of our patients.
Dr. Maheshwari, would you like
Can I just quickly add?
Yes,
I absolutely agree with all the points that Dr. Kaller has made. The other point, though, is it varies a lot with the GLP-1. So if you look at the head-to-head studies with, if you look at lixisenatide and exenatide BD, the weight loss is very modest. I would say it was less than with an SGLT2. If you look at liraglutide, that was the gold standard. Semaglutide has surpassed that significantly. Particularly with the weekly. And as you know, we were involved in the obesity program, the STEP program, which we published with the 2.4 milligram dose. So semaglutide, I think even in the diabetes dose, has significantly greater weight loss than we see with Dula or even with liraglutide. And of course, we've just published some data with tirzepatide, the dual agonist, which has remarkable weight loss. So it very much depends on the GLP-1 as well.
So would you use these drugs for weight reduction even in the absence of diabetes because they don't produce?
Yeah, so as you know, semaglutide's just got its indication for weight management in the US. In the STEP 2 study, the study I was leading, they examined the milligram and the 2.4. The milligram gives pretty good weight loss, and if you're using it in the diabetes clinic, I mean, I have lots of patients on 0.25, 0.5. But, you know, and you can get them up to 0.1, get very good weight loss, but it's dose dependent. So the higher you go, if the patient can tolerate it, the more weight loss that you'll get.
So I think we've now reached the end of our time for the sessions. If I would, anybody wants to make a quick point, otherwise I'll just quickly summarize. Fine, then I'll go ahead and summarize.
One thing I would like to make a point.
Yes, please. Yes, Dr. Maheshwari.
Just in a half minute or
sure.
What we find the difference between the weight reduction in SGLT2 inhibitors.
Can others hear him, or am I the only one?
No, I think we've lost him.
Okay, so then I will summarize. We have had a great discussion on SGLT2 inhibitors, GLP-1 inhibitor, agonist in management of diabetes, and of course in the whole spectrum of cardiovascular disease and heart failure. We haven't spoken too much about total heart failure management because this is more in relationship to diabetes control. As I can see from the slides, we should not only look at sugar when we treat diabetic patients. Of course, that's the primary thing. We need to control the sugar. There's no doubt about that. But we need to look beyond that. There will be certain groups of patients in whom you want to add aspirin, especially the high-risk group. A large number of our patients would be on statins, and Dr. Davis mentioned that certain patients may not be. Some suggested certain age limits. As a cardiologist, seeing a lot of cardiac problems at a young age and a lot of diabetes associated with it, my tendency is to use statins a little bit earlier in almost all my diabetic patients. As far as SGLT2 is concerned, it's an extremely good drug, especially in patients with heart failure. And it's such a pity that we have about 20 or 30% of our patients, or even less, with heart failure with reduced ejection fraction who are on SGLT2 inhibitors. And of course, GLP-1 are very much less, and especially from a cardiologist point of view, when you come to injectables and GLP-1, the use is even less. So we certainly need to make our diabetologists use more and more so that automatically our patients with heart failure and coronary artery disease get more of these beneficial drugs. So I think we should put aside the inertia for using these drugs, which have been found to be extremely beneficial. I've not seen a single trial yet where SGLT2 has not been of benefit whenever the trial has been done, except for the trial in COVID, which was negative, which was published in ACC. So it has no benefit in COVID, but other than that, SGLT2 trials have all been positive, and almost all of them have been dramatically positive in terms of benefit of cardiovascular disease, heart failure, and very importantly, also kidney disease. So I think we need to incorporate these drugs in the management of our patients. So thank you very much to all my panelists, and thank you very much, Professor Davis, for all your time and the tremendous amount of information that you gave us. So thank you very much to everybody, and over to Dr. Abhijit for closure.
Thank you, sir. Now I request Mr. Pasha, who is the divisional head of metabolic division. I request him to please come and give vote of thanks. Mr. Pasha.
Yeah, thank you, Dr. Abhijit. We have come to the end of a wonderful academic feast, and I would also like to share with you people that we had almost 2,788 registrations for this program before the program started, and we have almost around 1,368 delegates listening to all of you experts. I would also like to take this opportunity to reaffirm Alkem's commitment towards science-based medicine, evidence-based medicine. It will be only fair to thank all the experts who have made this program a grand success. I would like to take this opportunity to thank Dr. Davis, Professor Davis, Dr. Jamshed Dalal, Dr. Pramila Kalra, Dr. Sujay Ghosh, and Dr. Anup Maheshwari for their wonderful contributions towards making this program a grand success. I would certainly like to, hear from you guys more and more. And, Dapanorm Conclave continues. And this is a continuous series which is happening over a period of last 12 months. And this continues every month. And thank you very much for being a part of the Dapanorm Conclave. And thank you very much for all the delegates for coming in numbers and, really interacting and making it a grand success. Thank you to all the doctors. Thank you very much.
Thank you very much. Bye-bye, everybody. Bye, Professor.
Bye-bye.
Thank you.
Bye, everybody. Bye.
Bye.